So I'm going to tell you a little bit about improving foot care in across the city and what we can all do as a group to improve outcomes, because it is clearly one of the most feared complications of diabetes, isn't it? So what does good foot care look like? So when anyone gets asked, when the great and good get asked a question, what do? They go and write a guideline. And these are just some of the guidelines that are out there. And of course, you've all read every single one of them, right? Even I wrote one of them, so there you go. But nobody ever reads them. They collect dust on shelves. So this talk is not about guidelines. It's going to try and talk to you a little bit about some practical tips of the kinds of things that you can do to help improve foot care, and it ain't rocket science. So, my top tip, number one, only have 2 tips. We're talking about 5 tips, but I'm going to focus on the 2 most important ones that are relevant to you. Is focusing on education, both yourselves and also of the patients. Why is that important? This is all data now. But we did a root cause analysis of all the patients who had amputations in Sheffield many years ago. And of those patients in whom we felt the amputation was avoidable, delayed referral was a factor in a quarter of those unavoidable amputations. More interestingly, of the patients who come to our foot clinic with a diabetic foot ulcer, a third were not attending the foot protection team. Now remember, foot ulcers don't happen in isolation. These patients will have had an at-risk foot for many years before they developed their foot ulcer, yet a third of them were not attending the foot protection team. Half didn't even know they had an at-risk foot. And 2/3 couldn't recall, didn't mean they hadn't had it, but could not recall ever being told how to look after their feet. Now, it's not surprising if you don't know that you have an at-risk foot and you don't know how to look after your feet, you end up with a foot ulcer. Okay? So that's why educating them, engaging with them is important. And also ensuring that they attend the foot protection team, because attending the foot protection team results in much better outcomes. How do I know? Again, we've looked at our data. It's a complicated graph, don't worry too much about the details, but essentially what we found was if you were attending the foot protection team before you developed your foot ulcer, your time to healing was significantly lower. So if you were attending the foot protection team, your average time to healing was 10 weeks. If you weren't, it was 15 weeks. And that was simply because you were presenting later and you were presenting with more severe ulcers. Okay, because you didn't know that you should seek attention when you developed a foot problem. Lots of reasons why, but we can, and then you can read them on the slides. I'm not going to talk to you about that. But essentially, it showed attending the foot protection team confers significant benefit. I have 2 questions for you. Of all of the people here who are involved in screening diabetic feet or in your practices, how many of you have attended a training program in the last 3 years? It's a rhetorical question, don't put your hand up, okay? And how many of you, if you have patients with at-risk feet, do you know how many of them are actually attending the foot protection team? Because if you don't know the answers to these 2 questions, then how do you know that the care that you're providing to people with diabetic foot disease or with people with at-risk feet is actually effective? Do you have any systems in place to interrogate the data you collect to improve the care you deliver? What do you do every day? You sit there and you click these things on computers, collecting data for, what are you collecting it for? It's not for some random, data collector in NHS England, so you can, tick a box. Okay, The reason collecting data is it's to help you improve your care, the care that you deliver. But we don't often look at our data. We just collect it and go, it's fine. Tick my cough box. But increasingly, we will be asking some of these questions when we start looking at foot care services across the country, but particularly in South Yorkshire. My top tip number 2, walk a mile in their shoes. By that, what I mean is you don't really understand what's happening to your individual patients unless you walk a mile in their shoes. Don't literally walk a mile in their shoes. Probably not a great idea, not hygienic. But you understand what I'm saying here. And that's because, okay, people keep changing my slides. Now you can't see my picture. Anyway, never mind. Can you see this picture? No, not very well. It's meant to be a castle being invaded by the hordes of army and the defenders, which is probably your reception staff up here, trying to hold them off. Okay. But it's true. Most pathways are designed for the convenience of healthcare professionals. And when we feel overwhelmed because of that tsunami of patients out there, we create barriers to access to healthcare. Sometimes deliberately, sometimes not. But more often than not deliberately. But those barriers create delays in patients accessing healthcare and result in worsening complications. This is data from the National Diabetes Foot Audit. What it shows here is that the delays in terms of time to first expert assessment, the longer it takes from the time they present with their foot ulcer to when they attend the MDFT, the greater the proportion of severe ulcers. It also shows from time to first expert assessment, in terms of those who are alive and ulcer-free at 12 weeks, fewer are alive and ulcer-free at 12 weeks if there's been a delay, because you're presenting with more severe ulcers. Delayed referral, poorer outcomes. Ain't rocket science, guys. And those delayed referrals, resulting in more severe foot ulcers, come at a cost. Come at a cost in terms of pounds and pence, but also in terms of the impact in terms of morbidity and mortality to some degree on individual patients. Okay? This is again some of our local data, don't worry about it, okay? If we get an ulcer in Sheffield, early, a mild ulcer, okay, it heals on average in 12 weeks, and the cost of healing that ulcer is just about £1,000. If that ulcer is a severe ulcer by the time you see it, it takes 16 weeks on average to heal at a cost of £6,000. Six-fold difference. But that cost reflects all the things that we have to do, the hospital admissions, the intravenous antibiotics, all the offloading, the inconvenience to the patients, the multiple appointments to foot clinic, all of the things, that entire industry that we have created in our MDFT, which can all be avoided if we can catch them early. So simplifying pathways is crucial. Okay, and these are many of the things we've done in Sheffield. I'm not going to talk a lot about some of the things because these are historic. I did want to mention very briefly one of the things that we are doing increasingly, which started with COVID, which is the virtual MDFT. So when we offer advice and guidance instead of a physical review, if appropriate. So it started because of COVID-19, but essentially what we did was we've created a virtual MDFT where we give you advice and guidance instead of seeing them physically in the foot clinic. And it's mainly for those with relatively minor ulcers and also to some degree for the highly vulnerable and frail patients who are in nursing homes and would struggle to get to clinics. We ask referrers to send an image of the lesion with the referral, and all referrals are triaged by a diabetes foot consultant within 1 working day, and our latest data shows that we do that for about 90% of referrals. What are our outcomes? So our outcomes are pretty good, because when you set up a new service, you want to make sure you're not going to cause any harm by seeing these people remotely. So of those patients who do come through our service, 60% have healed within 90 days, which is pretty good compared, when you look at mild ulcers in the national data, it's equivalent numbers. In terms of complications, it's just, a quarter of them do end up coming back to our service. Okay, so if you do see a patient and we manage them remotely, occasionally they do need to come back, do need to come in to see us. A quarter of them do. But in terms of foot-related admissions and amputations, are very low levels of complications. And we do a root cause analysis of every amputation that happens that we manage through this service. And so far, all of the ones that we've looked at, we don't think changing the way they were managed would have made a difference to the ultimate outcome. So, with all of these things, how are we doing in Sheffield? This is the good news story. Okay, you can't see this graph now. I don't want to bore you with the details. But these are the trends in ulcer severity across Sheffield. So what we've seen, there was a bit of a problem with the numbers of ulcers we submitted to the National Diabetes Foot Audit over time, but that was mainly, I think, because a large number of these ulcers we're now managing in the community, and we don't currently have a system of entering the data from them into the national audit. And of course, there was COVID around this time, so there may have been some problems with how we completed our audit forms. But anyway, the proportion of severe ulcers has increased from 43% pre-COVID to around 50%. And this is in large part because, as I mentioned, most of the mild ulcers we were managing in the community, and we weren't submitting them to the audit. However, when we look at our data for ulcer healing, so despite having a much higher proportion of ulcers submitted to NDFA in terms of severe ulcers, we have amongst the highest levels of healing by 12 weeks across the country. 65% of ulcers healed within 12 weeks, and that is much higher than most other leading centres. And very important to me, because I'm small and petty, is that we are absolutely kicking Leeds' butt. Okay? So, and this is due down to not me as an individual, this is down to the hard work of every single individual in this room who takes part in the service, refers us into our service. So, in summary, what do I want you to do? I want you to ensure that if you are involved in screening and looking at people's feet, you have attended the training and you understand our Footcare pathway. Okay? If you have patients who are at risk, please make sure that you refer them to the foot protection team, community podiatry essentially, and check that they're actually attending when you see them for our annual review. If you see a patient with a diabetic foot problem, please refer them to the MDFT. I do not care how mild the problem is. Okay, I get 40, 50 referrals a week at the moment. But that's what's result. And sometimes they're just a tiny little blister or a cut on the foot. If I think it's fine and you can manage it in the community, I'll let you know. But it's joint decision making. But what it allows me to do is to monitor them and follow them up to make sure that they are getting better. And if they're not, we can pull them back in. Or if you're worried about it, you refer back and we'll pull them back in. Okay? No problem. No question is too stupid. Genuinely. Okay? We're here to give you that advice. And the hotline is there also for urgent advice if you need it. And lastly, thank you all very much, because this is down to you. The results that we're getting in Sheffield, the improvement we're seeing in Footcare in Sheffield, is down to the people out here. Thank you very much.